Indiana University. So these two people are going to give us more detail on the clinical aspect and also imaging findings. We're going to have Dr. Isaac Wu, who is one of the popular lecturers that we know at IU and also in Thailand, and has his own YouTube channel, going to give us a talk on the imaging aspect for the demyelinating lesions, including like a MS and NMO and anti-MOG. And we also have Dr. Laurence Walsh from the Pediatric Radiology, Pediatric Department, Pediatric Neurologist from Indiana Riley Children's Hospital, giving us a talk on the clinical aspect and on the clinical presentation. How can we differentiate like any disease? Can we really make the clinical diagnosis on those things? And Dr. Walsh, also the popular social media influencer on the stock, on the Instagram. So if you want to check out on his like a fashionista or something. So, and today I also have Dr. Namphon Tavi Asani from Julapur Royal Academy help us moderating this session. So welcome everyone to the session, and I will leave it to Dr. Wu and Dr. Walsh who want to give the talk first. You can start now.
Okay, let me start. I'll share the okay. Can everybody see my screen okay here? Okay, great.
Yes, we can. Mm-hmm.
Okay. So good morning from US, and also good evening, people in Thailand. Thanks for joining our section today, and thanks Dr. Walsh for joining with us. And we're very lucky to have him as a clinical aspect to tell us a lot more about the clinical side that we often don't hear about in our radiology lecture. So we're going to focus today on the demyelinating disease, particularly acquired demyelinating disease. Mainly, we're going to talk about four types. So we have MS, NMOSD, ADEM, and MOGAD. I think this, even if you do not do pediatric radiology, many of you will encounter this in adults as well. And in fact, some of them are more adult disease than pediatric. So I think that's a good topic that we can dive into. So usually, if you have any questions, please feel free to ask anytime. So to me, like when I look at this, all these different abbreviations, it seems like a bunch of word salad, right? You have multiple sclerosis, you have NMOSD, so neuromyelitis optic spectrum disorder, acute disseminated encephalomyelitis. I think many of these diseases are quite familiar to all of us, even if we don't really encounter them, at least we study about them in medical school. And some of the disease that's probably not as familiar to, especially to radiologists, would be things like MOGAD, which the clinician, of course, know a lot more than us. So it's also something that is good to just for us to all learn about. Just very quickly, so everyone's on the same page. And in general, a very, very simple diagram about histology about brain tissue. You have white matter, of course. And if you look at this cartoon diagram, the schematic about brain tissues, essentially you have neuron versus glial tissue. The main focus for disease process today is going to be glial tissue. But as you know, neuron is comprised of a cell body, and you have an axon that's wrapped by myelin sheath, and that helps with your conduction and sort of the wrapping on the wire, if you will. And the part we're going to focus on today is the glial cells, which literally it means glue. So in the old days that we think glial cells are just the glue that holds all the neurons together, so the supportive structure. Now, of course, we know that they provide much more than just a supportive structure, but that's one of the main functions. So we have microglia versus macroglia. We're going to focus on macroglia, which with three components. We're going to look at astrocytes, oligodendrocytes, and ependymal cells. As in this diagram, you have astrocytes that, again, in the past, that we thought is mostly just there to provide a physical structure for neuron, but it's much more important than that. But of course, it still provides the physical structure for neurons, but it does has holds a bunch of important functions as well. And oligodendrocyte, as you know, is an important one that helps making as well as maintaining the myelin sheath. So it's vitally important for demyelinating disease or demyelinating process that often affects the oligodendrocyte, especially affects the myelin. And the ependymal cell is nearby the CSF. It helps regulate the CSF homeostasis. So those are the three main type of macroglial cells. If you look at the pediatric white matter disease in general, you can roughly break them down into demyelinating disease as well as dysmyelinating disease. So a very rough definition, basically, if you think about demyelinating disease, that's what we're going to focus on mostly today, is essentially you have a process that the myelin is normally formed, but something happened, something bad happened to myelin. So you have a process that destroys the myelin. And in the early stage, the axon is going to be relatively spare. Compare that to dysmyelinating disease. Those are the leukodystrophy that we talk about, or metabolic disease, that a lot of them, the myelin is not normally formed at first place. So example would be, some of them has a classic feature such as adrenal leukodystrophy. It has a posterior distribution, but many of them are, in fact, all of them are very, very rare. Dr. Walsh is our expert in this disease entity, and unfortunately, that's not what we're going to talk about today, but just sort of the general category. I think we cannot talk about demyelinating disease without talking about MS. You know, that's sort of the big honcho, if you will. I'm going to cover mostly imaging aspect, and Dr. Walsh will talk about the epidemiology and the clinical aspect. But just briefly, the reason everybody know about MS is just because it's something that we study since before medical school, and it's a most well-studied demyelinating disease because it's also the most common primary demyelinating disease in number. And despite how well it's been studied, really, the underlying immunopathologic etiology remains unclear. There's not specific biomarkers. Some of the demyelinating process that have, as you will see in a little bit. We all know that there's certain characteristic about MS. MS is mostly an adult disease, a young adult disease, and it affects more commonly in Caucasian and female more than male, as we all know, statistically speaking. And then in the States, we all remember there's a peculiar distribution about MS in that the higher incidence, if you draw the line 37th parallel, there's an increased incidence compared to ones that are closer to the equator. And that's the same thing around the world as well. If you look at Southeast Asia, in Thailand, the closer you are to the equator, the incidence goes down. So, of course, even though it's mostly common in adult, obviously pediatric can also affect by MS. Pediatric MS is someone less than 18 years old. You account for less than 10% of the MS in number. But because MS is so common, even though you have less than 10%, that still account for a lot of number of MS. So if you talk about MS, obviously you need to know about McDonald criteria about the diagnosis. For radiologist perspective, from imaging perspective, we need to be familiar with what it's important in McDonald criteria, what is considered more likely a MS lesion. Because many of the disease processes, as you know, in real life is quite non-specific. And so what is McDonald's criteria? What are they looking for in terms of imaging that makes lesion more likely MS lesion? The buzzword here that I think most of us have heard about is this dissemination in space and dissemination in time. Dissemination in space is easy, just different location. That for radiologists is very easy. You just look for lesion in different separate category, different separate territory. That's dissemination in space. Dissemination in time is a little bit trickier. But basically, it's lesions that behave differently over time. And in the past, you require two separate images, because how can you tell if a lesion behaves differently if you have only one single set of images? But now you can actually use one single set of images to determine whether or not there's qualifies dissemination in time. In that, if, say, one lesion enhances, other does not, that can also qualify as dissemination in time from imaging perspective. And other thing that as a radiologist, that's good to know what is McDonald criteria looking for in terms of lesion that's more specific for multiple sclerosis. And there are 4 separate type of lesion that they consider is more specific. The one that's periventricular, the one that's juxtacortical/cortical, the one that's infatentorial, and the ones that's in the spinal cord. So this is a picture of subcortical U fiber. So the lesion, for example, this is a classic picture of a young person has a multiple sclerosis. The lesion that's juxtacortical is the one that extends all the way to gray white matter junction, such as that one right there. That one is subcortical. It's not exactly abutting the gray white junction. And the one next to ventricle, naturally, is the periventricular lesion. So notice that within the category, subcortical lesion is not considered that specific for MS. I mean, obviously, you can have lots of subcortical lesion. It's just that in the eye of McDonald criteria, it's not as specific as periventricular lesion or juxtacortical lesion. So those are the ones that you sort of pay attention to. That is useful, for example, if you come across a person who has a lot of white matter lesion, but many of them, or most of them, is subcortical lesion, perhaps you are not looking at MS. So what are other classic picture or the typical picture for radiologists to look for as far as multiple sclerosis? The one that typically they are short and oval, and they are T2 and flare bright. There are many lesions that you can see on these flare sequences. And they have the particular configuration that's referred to Dawson's finger. So they are perpendicular to the axis of the lateral ventricle, either on the axial view or on the sagittal view. I suppose somebody think that look like a finger. I never figure out why that look like finger. So, but use your imaginations, right? And this is also Dawson's finger. You can see they are perpendicular to the axis of the lateral ventricle. And the involvement corpus callosum is also very common for MS, especially in older patient, especially one that involved in the callosal-septal interface, the undersurface of the corpus callosum. And the one that's not in the criteria, well, I suppose it's in the criteria because it's infatentorial lesion. But we also often see that MS loves the middle cerebellar peduncle. And MS, of course, can present with optic neuritis. And as well as you have the optic neuritis, they tend to involve in intraorbital segment, and they tend to be short. Compare that to other type of demyelinating process that we're going to talk about in a little bit. So short and intraorbital. And the spinal cord lesion, as well as brainstem lesion, that's also very common. That's part of the McDonald's criteria. And also this thing called T1 black holes. Basically is a lesion that's sort of quote-unquote burnout, if you will, is that if you look at some of the flare lesion, not all of them has T1 black hole, T1 hypointensity. And the more number of T1 hypointensity you have, and that has certain correlation with the disability. So sometimes it's sort of just look for that if you have multiple follow-up images. And enhancement. So as I mentioned earlier, sometimes MS can enhance. And usually that means that it's either is an active or a recent demyelination. The classic pattern for the enhancement of MS, they tend to be incomplete. So some people describe it as a horseshoe. So it looked like an Indiana Colts symbol right there. So this incomplete REM enhancement pattern, that's fairly characteristic for demyelinating process. Compare that to other common lesion like abscess, like Mets, tumors. They tend to have complete REM enhancement. So when I see this incomplete REM enhancement, I start to think about potential demyelinating process. That's not 100% pathognomonic, but it's pretty good. And this is a example from Riley of a pediatric MS. You can see on the post-contrast portion, you have this incomplete REM enhancement pattern again. Sometimes enhancement could be quite faint. There are multiple lesions that's characteristic, perhaps not this one in location, but this one that involve in the corpus callosum. This one's periventricular lesion, and they are oval T2 bright. This is another example of a pediatric teenager, also has a MS. Again, lesion that's periventricular. And this one has involvement of middle cerebellar peduncle, involvement of the corpus callosum with a callosal septal interface. And again, you see that incomplete REM enhancement pattern, the horseshoe enhancement pattern. For the core lesion, and this same patient right here has a core lesion. I know this does not project as well as on PowerPoint, but the patient has a small, short segment core lesion in the upper cervical spine. And on the cross section, on the axial view, they tend to be peripheral and often dorsolateral, but could be anywhere, but usually peripheral. So the core lesion for MS, they tend to be peripheral, they tend to be localized and short. So they tend to present with less than half of the cross section, unlike other demyelinating process that we'll see. So that becomes one of nice distinguished feature if you have multiple core lesions. And the short segment is usually less than 2 vertebral body height segment. That's the short segment. Again, compare that to other type such as NMO, they tend to present with a longer segment. And there's another lesion lower down, you can see it's also very short. And if it enhances, you can also have a similar REM enhancement pattern. But what I noticed that a lot of time they tend to be just enhanced like REM enhancement, not necessarily REM enhancement like in the brain. Sometimes MS can present quite differently or quite bizarre. Like in this case, this is another pediatric patient. The first thing I think draw your eye to is this very, very abnormal looking expansion of the splenium of the corpus callosum with quite a bit of edema. And you can see the enhancement pattern is quite different, sort of lacy but incomplete sort of the enhancement. So as a general differential diagnosis for radiology for the trainees, if I come across a lesion, a mass lesion that expands and crosses corpus callosum, there are 3 things that comes to my mind right away. I think about some type of infiltrating glioma, GBM, high-grade glioma, or a CNS lymphoma. They also love to involve central structure, especially corpus callosum, or some type of demyelinating tumor-affective lesion, including tumor-affective MS. And as I mentioned, the enhancement pattern is a little bit different. That sort of helped me differentiate. Also, age, of course, helped. But if you look at the enhancement pattern for CNS lymphoma, for example, in an immunocompetent patient, they tend to enhance quite homogeneously and solidly, like this lesion right here, despite how big it is. Very, very little central necrosis. And with a GBM, for example, high-grade glioma, they tend to enhance very ugly RIME enhancement, complete enhancement with lots of central necrosis. Looks quite different in this enhancement pattern. Again, also, if you notice that the patient has a lesion that involving the brainstem and middle cerebellar peduncle, patient of optic neuritis, this is a case of MS, tumor-affective MS. And for optic neuritis, they tend to occur in young patients, can be painful, and the vision deficit is variable. And this is, for some reason, I don't know why it surprises me when I first learned about optic neuritis, that I always thought that ophthalmologists can see things as well as we can. But it turns out there are optic neuritis that the ophthalmologists cannot see. And that makes sense, right? Because if you have a lesion that involving very close to the optic disc, of course they can see that as well. Or the lesion that involves an entire segment of the optic nerve, they can see that too. But if you have a typical MS lesion that involving the intraorbital, the sort of the short middle section, they cannot see that with their ophthalmoscope. So that classic picture of patient cannot see, doctor cannot see type. And then as we know, if young patient present with optic neuritis, really that you have to ask about MS history or family history. Also worry about the potential risk down the line. And in the landmark trial, in the optic neuritis treatment trial, that they gathered long data was the tons of people. And what they found is that over the lifetime, if patient has optic neuritis into adulthood, the overall life risk is about 50%, so it's quite high. But the thing is that the important thing to know basically is that for radiologists is we have to recommend getting a baseline brain MRI because having a brain lesion, white matter lesion, substantially affect the potential prognosis of whether or not patient has a lifetime risk for MS. If at the time of presentation, single event, the brain is completely clean, the lifetime risk is still pretty high, but definitely not as high as if patient has additional lesion. So just don't forget to recommend brain MRI with and without contrast. So we talk about MS can present with optic neuritis, but they are not the main presenting symptoms. There are other diseases that we're going to cover. So let's focus on the next one, that the optic neuritis tend to be one of the main clinical feature. That's NMOSD. So for NMOSD or neuromyelitis optica, historically it was referred to as Davis disease. That I don't think anyone called that ever anymore. You may come across that in some historic or textbook or Wikipedia. But I like this disease just because it's exactly what it should look like, what sound should look at, neuromyelitis optica. So it's presenting with optic neuritis, you can see that on MRI, and you can present with a transverse myelitis, especially longitudinally extensive transverse myelitis. So the name counts speak a lot for radiologists, so we know what the main imaging feature to look for. And compare that to, say, MS, where we know that the lesion tend to be short segment, peripheral, and localized. The optic neuritis or the core lesion for NMO tend to be much longer segment, that's MS right there, and they tend to be longer segment, typically greater than 3 vertebral body segments. And on the cross section, they tend to involve in more than half and often entire cross section for the core lesion. So that's one nice way to distinguish between this than MS, for example. And I think everybody knows that this is a separate disease entity. When I was a resident medical student, that I learned from textbook that NMO is a MS variant. And we know that, of course, that's not the case. The debate was over pretty much back in the early 2000s when they discovered the specific antibody biomarker for NMO. That's a aquaporin-4 antibody. And also at that time, by the way, the aquaporin-4 antibody, the aquaporin-4 water channel is embedded within astrocyte, within the foot plate of the astrocyte foot plate. You can see all this little water channel that's embedded across, and it regulates the water CSF homeostasis with vascularity. So naturally, they are going to cluster around where the CSF is going to be. So that's important from imaging perspective. So that means that they tend to cluster. If you see the finding in the brain, they tend to cluster around where the so-called aquaporin-4 channel rich area. So typically around the ventricle, around where the CSF is, as well, of course, in the optic nerve. So that means that you tend to see that around the sort of the lateral ventricle by the frontal horn, for example, and also around the third ventricle in the hypothalamus region. And you can also see that around the fourth ventricle. And around the central canal, then expansion, also the transverse myelitis, again, is long segmented. And another area that pay particular attention to is right by the ovax, by the cranial-cervical junction, the area postrema. Often or sometimes you can see the involve an NMO. So there are various findings that are clustered around this region or the aquaporin-4 rich area. So that's why in the past, when I was a trainee, the classic teaching was, if you see a patient coming with optic neuritis and you see some core lesion, especially long segment transverse myelitis and normal brain, that's NMO. But turns out the brain was probably never normal. It's just that it's much more subtle than other white matter disease that at that time we just didn't really looking for as much. So as I mentioned earlier, that's one of the area post-trauma is an important area for NMO. So on imaging, when you see a signal abnormality there, that's important because that's one of the main criteria, clinical criteria for that, in addition to the things that we know, optic neuritis and transverse myelitis. And then there are other clinical criteria that's not as common. The key thing that for the diagnosis to make clinically is that you have an NNO or aquaporin 4 antibody positivity plus one core clinical criteria. So as a radiologist, so we are looking for this area. And turns out there's also a subcategory that you can have an antibody negative NMO. Dr. Walsh will talk about that a little bit more, so I'm going to skip that. So you do need two core clinical criteria. One of them has to come from the top three. So you have the mild NMO spectrum disorder, so NMOSD. For imaging perspective, again, what does that look like? So look for the area that's rich in aquaporin 4, so usually around the ventricles. And also look for by the OBAC, so cranial-cervical junction. And also look for optic neuritis, and they tend to be long segment. And the place that to look for in the spinal cord is the long segment transverse myelitis. For the optic neuritis, you can see that this is a older patient with NMO with an antibody positive. You can see it's a long segment. When it's active, of course, you can see enhancement. Compare that to a MS patient where they tend to be intraorbital segment and short segment. So that's quite different. This is younger patient also has a aquaporin 4 antibody positivity, NMO. You can see that there's a long segment, and particularly NMO also can involve in optic chiasm. That's quite different than other disease entity, particularly MS. MS does not like to go to optic chiasm for some reason. So when I look at the optic chiasm involvement, one thing to consider is NMOSD. Here on the cross section, you can clearly see the optic chiasms abnormally enhanced in this case. And this patient also has a other feature that's in the aquaporin 4 rich area, such as next to the lateral ventricle, and you can see some involvement by the cerebral peduncle here. There is an involvement in the area of post-trauma. This is a younger patient from Riley, also is a antibody positive NMO. And notice that patient does have quite a bit of signal around the OBAC, around the area post-trauma. And this is another patient also with antibody positive NMO. Notice that the core involvement here is very, very long segmented, and it covers more than half of the cross section. So this is a classic picture for the longitudinally extensive transverse myelitis that you see with NMO, now with MS. This is a contrast to MS that tend to be short segment, peripheral, and localized. So again, does it matter? You know, because sometimes as a radiologist, we are not as attuned to the clinical aspect. So we make the diagnosis as there are some lesion, for example, sometimes tumor. You wonder that is it important to make that exact diagnosis? I would argue that the more important is go down the right pathway. So whether or not a low-grade tumor versus high-grade tumor, that's a good place to start. So sometimes you think about disease, you say, does it matter if you make the correct diagnosis of NMO versus MS? The answer is yes. It actually affects quite a bit, not only for the treatments, as well as the prognosis and management and everything else. So that's it. That's why it's important. In fact, some of the MS medication may make the MML worse. So it does matter. And just sort of the, again, just to kind of highlight the difference, if you just look for MS for NMO, especially if you're studying for board exam, I know some of you are focused on that right now, is that for the MS classic picture in the brain, you look for those dots and finger lesions. For NMO, you look for lesion in the brain that's around the so-called aquaporin 4 rich area, area postrema next to ventricle, etc. For the optic involvement, MS is short, intraorbital. NMO tend to be long segment and can involve in the optic chiasm. For the core lesion, MS tend to be short, localized peripheral, and NMO is long segment greater than 3 vertebral body length, involving quite a bit of cross-section area. Turns out, though, there are also subset. Remember, there's an NMO negative, aquaporin 4 antibody negative NMOSD. Maybe there's an overlap. So there's a disease called MOGAD, or that's what I'm going to talk about next. So MOGAD, or anti-MOG disease by different name, is MOG antibody associated disease, or MOGAD. What is MOG? Is myelin oligodendrocyte glycoprotein. So if you look at the oligodendrocyte as well as myelin sheaths, what you will see is that there are various proteins. The myelin oligodendrocyte glycoprotein is embedded on the surface of the myelin sheath, as well as the oligodendrocyte. The exact function is not clear, but many think that it serves a very important function. At least part of the function is an adhesion molecule. So imagine that if you have an antibody attacking this adhesion molecule, you can help disrupt the integrity of myelin sheath. So what is the antibody anyway, right? Initially, when you first discovered, this is not something that just discovered like 5 years ago. This was discovered a while ago, a couple of decades ago. When it first came out, there's a lot of excitement that's generated because people thought that they finally found the biomarker for MS. But turns out, as I look into it, that was not exactly the case. The trick here is that clinically, MOGAD can present with mimic just pretty much everything. Right? Can essentially present the same way as any other demyelinating disease, as well as encephalitis. For us radiologists, the problem also is that they can look like pretty much anything, just like all the demyelinating disease. Maybe not as much as MS, but sometimes they can also look like MS. So in other words, it's really not a pathognomonic feature for MOGAD. Another thing that I think sometimes, I remember I talked about this, I think the first time I talked about, give this lecture 2 years ago, maybe last year in the noon conference, and many residents come up to me, or several residents come to me and they said they never heard of this before. It's understandable, right? I didn't know about this 5 years ago either. Just for one thing, the assay is not commercially available until 2017. So this is also something that, quote unquote, relatively new, at least for radiologists. It's essentially right now is you want to test for the antibody, and also there's a diagnosis by, you have to exclude other potential entity, especially things like NMOSD. So not a pathognomonic feature on MRI or CT imaging, but there are some features that was more suggestive of potential MOGAD. So this is an example of a MOG antibody positive patient from Riley. If you look at the flare sequences right here, you can see clearly these couple of lesions right there. They can be any of the demyelinating lesion. It could be ADEM, right? Although ADEM tend to involve in a lot of time bigger area. Maybe this one's abutting the gray-white junction, so sort of juxtacortical. And there's another lesion that involving the cortex, a little bit faint. But patient does have a optic neuritis that's different than, say, for example, MS. Right? You can clearly see that there's a bilateral enhancement. So first of all, bilateral involvement optic neuritis is just not typical for MS. And it's long segment. And another thing that, and on the coronal view, that coronal view for the trainee, that's one of the best sequence to look for abnormal optic nerve signal. So for our orbital sequence, you have to have a coronal T2 thin cut through the optic nerve. Hopefully the patient doesn't move when you're doing that exam. You can see clearly there's an abnormal enhancement. Also notice that there's more than just the nerve itself. Sometimes you will see the involvement of the surrounding structure, including fat. You can have inflammation and around the optic nerve sheath, so-called perineuritis. And that is much more common with MOG as opposed to, say, MS, for example. And patient was treated 5 months later, looks normal. So this is something that it was talked about by multiple papers, talk about this spinal optic perineuritis, as well as bilateral optic nerve involvement that tend to point toward more MOGAD. Of course, it's not pathognomonic, but it's something to think about. And there are other more common features, not pathognomonic feature, but something that's more common that would make you go toward more MOGAD as opposed to other demyelinating disease. Again, perineuritis, as pointed out by another paper. And also this so-called the H sign, the transverse myelitis present with this H sign involving the gray matter, central gray, as opposed to the entire cross-section like you see with NMO or you see with ADEM. So this H sign, this is another different paper talk about the so-called H sign. Of course, they can also present like just your regular transverse myelitis, but sometimes they can present this distinct H sign. You know, if you think about it's Honda or Hyundai, depending on which car you like. And another thing that typically does not occur in other demyelinating process, especially not with MS, is the leptomeningeal enhancement, which does occur with MOGAD, and clinically they can also present with encephalitis. A couple of papers talk about, you can see this abnormal enhancement of the leptomeninges. So those are the couple of features to look for. And this is a patient from Riley that has a MOG antibody positivity, 17-year-old female. Probably doesn't project all that well on these FLAIR sequences. You can see the multiple white matter lesion, and there's a cortical involvement right here. And notice that the patient has some leptomeningeal involvement. And the patient's core lesion is a long segment. And here you can see sort of this is the best example that I can find in real life that look like so-called the H sign. Sometimes you just have to use your imagination a little bit, but I think it's pretty convincing. I think I can see a more involvement, just the gray matter, the H, rather than the entire core, but it is long segmented. This is another patient that has a test positive for MOG antibody at Riley, and this one you can see the lesion looks much more confident, look like ADEM, and the enhancement patterns also is relatively solid. Patient again has bilateral optic neuritis, and maybe you can see there's enhancement beyond just the optic nerve, so perineuritis as well. So another picture of MOGAD. And lastly, just talk about the overlapping ADEM. This is a more pediatric disease than adult. So as we all know, that we think it's cross reaction between some type of viral antigen and causes autoimmune attack. So that's why classically, especially on board exam, in real life, patients tend to present previously with some type of viral infection. That's the most common thing. And classically, it was thought as monophysics, and that's not entirely true, but Dr. Walsh will talk a little bit more about that. But for the purpose of board exam study, think of them as sort of the lesion that should behave exactly the same. This is an example of a 4-year-old comes in with ADEM. On the FLAIR sequences right here, You can see that there's a large involvement in the basal ganglia, mostly the putamen. You can see there's a small involvement in the right basal ganglia as well. You can see some area of a relatively oval-shaped lesion in the subcortical white matter. There's a couple of patchy lesions around. There's a few more dots right here. And multiple white matter lesions. On the core, you can see there's a involvement of a long segment, 1, 2, 3, 4. So at least greater than 3 vertebral segment expansion of the spinal cord. So you have long segment transverse, longitudinally extensive transverse myelitis. There's another smaller lesion that's more localized and short segment. This is another different patient, 7-year-old, also a pediatric patient, again with same type of clinical picture coming previously was a recent viral infection. Another confluent lesion that involved in the basal ganglia. This one has a larger confluent area of cortical, and 8 and 10 usually is bilateral and often asymmetric involvement of the white matter and sometimes along with the cortex. So that's the classic picture for ADEM. And ADEM, more than anything else, compared to, for example, MS, they like to go to gray structures, central gray. So involvement in basal ganglia make me think of ADEM more so than, say, MS. And here on the, again, it's a longitudinally extensive transverse myelitis, so long segmented. And sometimes, though, ADEM and MS can be very, very difficult to tell apart on imaging. That's why it's vitally important for us to talk to our clinical colleagues and get their input because they have a much better grasp about what's going on with the patient. And that can really help you to make you a better radiologist. But if you want to sort of just generalize, especially for those study for board exam, the thing that will make me think about ADEM are the one that if I see multiple lesions that involve in the deep gray, cortex, cortical involvement, deep gray, basal ganglia, I think ADEM over MS. If I think so bilateral, more diffuse process and often asymmetric, I think about ADEM more so than MS. If you see the Dawson finger configuration, the one that's perpendicular to the axis of the lateral ventricle, that's MS. If you see more corpus callosum involvement, for some reason, ADEM does not like to go to corpus callosum. They can, but they just don't go there as much as MS likes to go. So think about MS. If you see T1 black hole, that's MS more than ADEM. The core lesion, ADEM present with a long segment transverse myelitis, and MS is more short and focal. And just to summarize our talk, for now, there are 2 specific antibody for demyelinating process. One's for NMO, the other one is for MOGAD. MS still is elusive to us. And so a couple of features for radiologists that's helpful for us to sort of make our best educated guess as to what disease is what. If you see optic neuritis, if it's long segmented and bilateral, think of ADEM, NMOSD, MOGAD, much more so than MS. And if you see bilateral involvement, also think about MOGAD a little bit more. They tend to be, at least, they are more common than others present with bilateral, and others can present with bilateral involvement as well. If you see optic chiasm involvement, I think about NMOSD more so than other entity. If I see perineuritis, more than just the optic neuritis, but involvement of surrounding structure and orbital fat sometimes, I think about MOGAD more than others. The transverse myelitis, if it's a long segmented, think about ADEM, NMO, MOGAD more so than MS. If you see the H sign, the Hyundai sign, perhaps think about MOGAD, even though I have only, like I say, I haven't seen a lot of H sign in real life. Again, just quick summary, typical lesion, Dawson finger for MS, for MOGAD. If you have leptomeningeal enhancement, that's quite unique than compared to others. And if you see involvement in a area postrema that is more characteristic for NMO. The optic nerve, short segment for MS, long segment for MOGAD and for NMO. If you see bilateral involvement, think about MOGAD. If you see involvement of the optic chiasm, think about NMO. Lastly, spinal cord lesion, short segment for MS, Honda sign perhaps for MOGAD, and long segment for NMO and ADEM. And ADEM has a lot of cross feature. That's all for the imaging aspect of the acquired demyelinating process. Thank you.
Thank you so much, Dr. Wu, for the excellent lectures. Any questions from the audience here, or then we can move to Dr. Walsh. Hey, Dr. Walsh, since Dr. Wu give lectures and there is like a lot of overlapping imaging findings, is it fair enough if you can put like everything that he said in the differential diagnosis for you? Are you going to do the test on all of those things? Because there is a lot of overlapping, right? We cannot specifically say something. So if you said, okay, this likely acquire demyelinating lesions, such as 1, 2, 3, 4 on those things.
I think I can. In my talk, I do that a little bit, I think. Yeah, no, this was, I think we should all go home now. I think he pretty much just handled it, yeah, so no, let me share my screen here and see if I can get the technology to work for me.
Yes.
Update not now. I don't want to update the driver. Okay. Share content.
So Dr. Wu, I have one quick question.
Yes.
So I know that you talked about sorry, I think there's some little feedback echo here. Hold on 1 second.
Yes. Yosu, go ahead with your questions.
I think it's right.
Oh, no, I'm fine. Please keep talking. I'm just trying to figure out how to do this. Can you guys see my screen?
I can.
You can or cannot? I'm sorry.
I can, yeah. And I saw you as the virtual speaker or something on top of your screen. Is it? What should we call that?
It should be right now. It should say you should see my first slide.
I saw your first slide, and I saw your face on top of your slides, not in the window.
Oh, okay. I don't want to see my face in front of the slide. Let's see how I get
your whole face and body in front of your slides.
No, that's scary. Okay, just there. How do I get rid of it?
It's beautiful.
Yeah. Let's see. I wonder how to get rid of that. I think I put the wrong. Let me stop sharing for a second, and I'll start sharing again.
Okay.
Options. Hold on. Oh, here. There. Presenter mode. Screen. Now can. No, let's see. Now, do you see my slides?
Yes.
Yes. Perfect.
Yes, we can see now. Perfect.
All right. Excellent. Okay.
Yeah.
So, wow, I feel like I have 3 strikes against me. First, I followed Dr. Wu, who gave this exceptional talk. And then the second thing is that, I'm not really qualified to talk about images unless a neuroradiologist comes through and puts big orange arrows on the lesions. So I can then say, oh, that's where they are. And the third is, as my wife, who's a child psychiatrist, will say, neurologists are viscous human beings. And so we'll talk about things longer than anybody else wants to, and they've all gone home and everything. So I'll just apologize in advance. Also, I'm going to be asking a bunch of neuroradiologists to use auditory cortex rather than visual cortex, which I think is probably a travesty, but I'll do my best. So I'm going to fill in some things clinically, do my best here about what Dr. Wu said, and I said he gave an incredibly clear talk about these things, and I think this looks like the type of high yield talk that you would want for boards. Let's see if I can make the slides go. Okay, all right, I have no financial support or conflicts of interest to report. And so basically, I think the subtitle for my talk is how can I help you as neuroradiologists, and how can you help me as a child neurologist? Or to put it in the immortal words of Tom Cruise and Jerry Maguire, help me, help you, could say help me. So acquired demyelinating disease in children, I think is, and I'm really going to stick to pediatrics, is best described or understood as acquired demyelinating syndromes. And my training was in child neurology and then clinical genetics. And so I think in syndromes, even when maybe I shouldn't be thinking in syndromes, but I think in syndromes. It's just easier for my brain to work that way. And these differ in adults and children. They vary in the clinical presentation and what happens to the children. They dim in the imaging findings and the pathophysiologic processes Dr. Wu pointed out so eloquently. Often, sometimes we can make the diagnosis right off the bat, the first presentation, but often it takes us longer, months, and sometimes even years to know what we're dealing with. And just for comparison, when I was in training, so I'm older than Dr. Wu is, so when I was in training, we had multiple sclerosis, and we had ADEM kind of, and we didn't know all this, the fancy stuff about NMO or MOG or anything like that. And our understanding over the past 15 to 18 years, I think, is really evolving with these disorders. So, why do we care about trying to separate these things out as much as we can? Well, just like about everything else, a proper diagnosis is important to, understand what the child's going to do and how to treat them. And I think it is vitally important for you guys and us to understand, as neurologists, that the neuroradiographic picture may be the key to diagnosis in a lot of these things, if not all of these things. And as that gets more and more fine-tuned, some authors believe that it's better than even the CSF biomarkers, which I clearly do, I think in a lot of cases. And that's why Dr. Wu's here. So I divided these up, as many folks have, into kind of clinical, radiographic, serologic pictures, I think is the best way to put it. And I'm just going to go through those kind of quickly here. So first you have, this is kind of an old term, CIS, clinically isolated syndrome. It's basically, I think, what we call it now, and we don't have a better name, but it has to be over 24 hours in duration. And the thing is about a clinically isolated syndrome, which these are, these two are especially, you may be changing your mind later on as the child evolves. You can divide these further into typically monophasic and typically relapsing disorders, and you have to realize that typically has to be that modifier because they don't always behave like they're supposed to. So optic neuritis, so isolated optic neuritis, isolated transverse myelitis, and then ADEM, and typically relapsing NMOSD, MOGAD, which can fit in either category pretty readily, and then multiple sclerosis, which obligately fits in this one. So 2 rhetorical multiple choice questions. What percentage of children with MS ADS should be non-MS ADS proceed to a diagnosis of MS? And so I'm just going to tell you. So the answer, the published answer is somewhere in here. The actual, but if you actually read more of the literature, it's all of the above. And then morbidity is often substantial in non-MS ADS, true or false. So I put this one in because I think a lot of us, when we first see a child with demyelinating disease, acquired demyelinating disease, the 900-pound gorilla in the room is, does this child have MS? What's the chances of this child having MS? But if you look at it, compared to some of the things that could happen to children with some of the non-MS related disorders, MS may not be the worst thing that can happen. And so we have to acknowledge that with families and in treating the child also. There can be worse things. So acquired demyelinating syndromes, we're just going to go through these pretty quickly. Optic neuritis, which is obviously inflammation of the optic nerve. It can be pre-chiasmatic or chiasmatic, and pre-chiasmatic, obviously anterior to the chiasm. The spatial involvement, as Dr. Wu had pointed out, can inform the ADS subtype. About a quarter of children presenting with a first bout of an acquired demyelinating syndrome present with optic neuritis. Typically a little bit older kids, and then females slightly more predominant than males. This was my sad attempt at a graphic. It's the only graphic I have in here, I think. So as Dr. Wood pointed out, if you when you break these down in some of these later categories, MS tends to, in a single attack, tends to be unilateral and more in the intraorbital section of the nerve, shorter segment. MOGAD, bilateral, NMOSD can be bilateral, unilateral, but it tends to involve more posterior and chiasmatic involvement. How do these kids present? So it typically evolves over the few days. It's not going to be acute, sudden, immediate vision loss, such as in a acute ischemic optic neuropathy, as you would see in an adult. It's going to take a couple of days to a few days. We had a teenager who came in with a week of progression, 5 days of progression of vision loss before they were presented to the emergency department. That's another story. Decreased acuity. Half to 3/4 of the children are worse than 2200 at their nadir. And so that's significant. I mean, that's, you're seeing stuff about here. Visual fields defects, specifically optic nerve disease, tends to give red color desaturation. That's something that we can sort out at the ophthalmologist. And then if it's unilateral, obviously you're going to have an afferent pupillary defect. So those are things we look for. So if we say there's an RAPD where, the pupils dilate if you shine it in the bad eye, that's helpful. Pain, especially with MOGAD, as we've talked about with perineural involvement, you have pain with extraocular movements. Disc edema is often seen, but not always seen. And in children, it is about half the time it's bilateral, especially as you get into younger age groups. So my evaluation slides look a lot like each other. So we go through these, and I'm not going to mention history and physical examination again, but obviously that's where everything starts for neurologists. We want ophthalmology involved, and they can do this really cool thing called optical coherence tomography, which I'll have a slide of coming up, and which is helpful. And then orbital and brain MRI with and without gadolinium. And I would agree with Dr. Wu that if we see a child with optic neuritis, we want brain MRIs. One question is, do we want spine MRIs? And there's some guidance about that. If a child has myelopathic, not myopathic symptoms, or if there are other things that make you suspect MS or NMOSD in this child, then we want a spine MRI with and without, and we want total spine. I spent a lot of time on peer review phone calls with insurance companies saying why we want spines and why we want the whole spine and not just part of the spine. And so it's important, I think, to stick to your guns and try to do the whole spine. CSF examinations, but I'll talk about, I kind of cluster those things on a later slide. And then serum, if I see this, I'm going to want our antibodies of choice today and in the serum. And children with optic neuritis, anti-MOG antibodies can be positive in 70% of children with bilateral disease, again, as that one slide showed. But aquaporin 4 actually are rarely positive in bilateral disease, interestingly. This is OCT, and basically, to put it in your guys' terms, it's kind of ultrasound with light, I think is the best way I've heard it described. And so it deals with, fraction off of the various layers, cell layers of the retina. And it's especially in the high resolution black and white images, it's exquisitely detailed. It basically looks like a micrograph of the retina. And the fiber layer that we're interested in for this discussion is the nerve fiber layer, the retinal nerve fiber layer up here. Here, and so here's the optic cup right here. And this is an example. So this is a person's good eye, and this is a person's not so good eye. So a person with papillitis or an anterior optic nerve lesion. So the area of the retinal nerve fiber layer is then transformed here, and you can see it falls within the, somewhat robust, but within where you would expect the curve to look for an average thickness for an optic nerve, for a retinal nerve fiber layer. This person, this eye is grossly swollen, the optic nerve head, and you see a much thicker layer qualitatively and quantitatively. And then say this were not just optic neuritis, say this were multiple sclerosis, and later on the nerve fiber layer atrophies, then you would see the converse where the black line would end up being down here. So this is a useful tool for the ophthalmologists. Prognosis with isolated optic neuritis, half to better than 3/4 improved to at least 20/40. It makes a difference whether aquaporin or MOG antibodies are present, mostly because if they are, and they're robustly present, not just weakly, we got a little peak there of antibodies for MOG, argues against this being MS. The risk is MS increases if it's an older child, if spinal tap is performed and there are at least 2 CSF-specific or unique oligoclonal bands, if there are concurrent lesions consistent with MS, which makes sense. Really high at that point, it's lower, and some folks would quote it lower risk still, even without these. Moving on to transverse myelitis, so inflammation of the spinal cord. So it matters where and how much, and Dr. Wu went through most of these. One thing that I've kind of learned over time, that cervical lesions maybe aren't so good to have compared to caudal lesions as far as what they predict. MOGAD tends to be a little more distal, involvement in the spinal cord. MS tends to be more rostral. But about 80% of them will still have thoracic involvement. Dr. Wu talked about this already, and very eloquently. This is really a disease of kind of preschool and puberty. So even though the mean age is about like 8 or 9, that's not really representative because there are 2 peaks, and this represents about a 1/5 to 1/4 of initial pediatric acquired demyelinating syndromes. It's rare. Male to female ratio is about 1:1. Clinical presentation almost always involves some degree of paresis. Again, typically mostly with lower extremity involvement, which makes sense considering the distribution of where the lesions are. But about 40% have arm involvement. Sensory disturbance, sphincter disturbance is high, and it's underappreciated. It could be a significant part of the disability. And then autonomic dysfunction. If you have a giant central cord, holocord lesion involving your thoracic and upper lumbar spine, your sympathetic nervous system probably isn't going to do well. And these children can be quite sick with autonomic dysfunction because of that. The other thing is you can miss sensory levels. It's like T10, T6, in a 3-year-old, or autonomic dysfunction, or even a 2-year-old, right? 2-year-olds aren't potty trained yet. And so it may not, parents may not realize that they have bladder dysfunction. And so I think some of these numbers are underrepresented in very young children. Evaluation, MRI brain and spine, looking again for the longitudinal extensive lesions. You may see, it's permissible to see non-specific brain involvement, a few little subcortical ditzels, white spots, and not say that this is MS. CSF examination shows pleocytosis, so we see white blood cells. Often we see elevated protein. We tend not to see, unless this is going to be MS, we tend not to see oligoconal bands, and about a quarter of the time it's normal. And we want these antibodies and then other serum tests, which again I'll get to. Most of these children, isolated transverse myelitis represents a monophasic illness, but we don't know that for some time. And better than half have complete recovery, half to three quarters, although still 20 to 25% are left with residua. If it's MOG or aquaporin 4 antibody negative TM, we look for other, these MOG is a good prognostic sign in this real MOG. Aquaporin 4 may or may not be, as we'll get to. But then if we don't have these, then we're worried about MS. And so we look for other things. We actually want to see some white blood cells. If we don't see white blood cells in the spinal fluid, we start worrying more about MS. We don't want to see quadriparesis, which is self-evident, I think. We don't want to, and we want to see, actually, it takes them a long time to get to their worst. Conversely, if they are very young children, if they have rapid progression, and more severe symptoms, then it's a worse prognosis. And about 10% of these children will go on to develop multiple sclerosis. Even if they don't, it takes them a long time to get better. Month or two to walk if they've lost walking. But the other thing, it can take 6 to 12 months to get normal sphincter control back, bowel and bladder function. And I think that's undersold a lot of time to families. These are the kids that end up going to inpatient rehab a lot of times, or go home with a Foley catheter. So aquaporin 4 antibodies are positive, very low percentage of kids of transverse myelitis, isolated transverse. But if you have it, it suggests you're going to have a high relapse rate. MOG is a little more likely to be positive, and while the recurrence rate is higher than if you don't see any antibodies, it's still, and you don't have MS, it's still lower than this recurrence rate. MS risk increases, makes sense, right? If females, because females also have a higher risk of MS. If you see significant oligoconal bands, or if you see brain lesions consistent with MS. Moving to acute disseminated encephalomyelitis. So this is the third of the typically monophasic ADSs. So you have to have encephalopathy. You have to have some sort of involvement of, you have to have some sense of involvement of the sensorium, irritability, sometimes fever, seizures, and so on. That's just part of that there is ADEM without encephalopathy, but then we don't think about it as ADEM as much until proven otherwise. Plus, you have multifocal CNS involvement. As Dr. Wu's slide showed, this is a multifocal disease presentation. And about 10 to 30% have spinal lesions. This, unlike the other disorders we talked about, this tends to be disease that hits younger children more than older children. And males are slightly more represented with this one. Typically, it follows from some sort of a fairly non-specific infection. Rarely vaccinations have been implicated, but most of the time it's a non-specific viral infection, and it can be as early as 2 days, it can be as late as almost a month. And we find that about a half to 3/4 of the time. The chances that we're going to isolate the bug that caused it, of course, are about nil. One, we're not very good at isolating viruses, even with PCR, and two, the virus may be long gone. That's a question parents frequently ask. Sorry. Just make this quiet. There we go. So how does this present? So rapid onset, not immediate acute, but very rapid over the course of a couple of days to a week. They often will have, apart from the viral infection that has come and gone, some prodromal headache, fever, not feeling good, and then they have encephalopathy plus multifocal CNS involvement. And you guys can read these, but motor problems predominate, plus ataxia. The interesting thing about children and young children is there's a pretty substantial number that have seizures. And this is something when a child shows up in the emergency department with seizures, this is not what we think of automatically. And I had one child maybe 4 years ago or so who was very instructive for me because that child showed up with seizures. We got an MRI scan immediately. Child presented in an afternoon with seizures. Got an MRI scan. It was normal, but had 2 or 3 seizures. And we said, okay, we're going to observe the child because we didn't really feel comfortable sending the child home, and watched him overnight. Next, like a day and a half later, I think he wasn't feeding well. Started getting kind of ataxic, and then started getting ataxic. We did another MRI and just had fluoride lesions consistent with ADEM. And so it taught 2 things. One is the seizures can be a first presentation. Second thing is you can get your MRI scan too early sometimes, even though you have to get it. Aphasia, isolate, a lot of focal findings and so on. This can be really severe. If you have a brainstem lesion, it can take out your respiratory drive and you may be on a ventilator. Most people are going to nadir within that first few days. I've seen it happen longer than that with not great outcome, interestingly, but usually within the first 3 to 4 days. So these children, again, MRI brain and total spine with or without gadolinium. We expect to see probably a few more white cells, but sometimes it's completely benign looking spinal fluid, elevated protein. Unlike some things like TB or cancer, glucose is going to be normal. Usually we don't see OCBs. You can see non-specific ones, so that just means that we look for MS, we look for intrathecally or CSF unique oligoconal bands. We should see some peaks, at least 2 peaks of immunoglobulins. And if but they compare that to serum. And so if the serum and the CSF have the same peaks, then at that point they're not really specific and they're not predictive. But if they're only in the CSF, that gets us more concerned. We would generally send aquaporin and MOG in this. As Dr. Wood said, MOG tends to be present more likely. This is typically in 90% of children monophasic, and most children do fine with complete recovery. About 10 to 20, about 20% or so have recurrence, which is called multiphasic ADEM. It can recapitulate or there can be recrudescence of the same symptoms, and you want to have it happen after at least 30 days after the initial bout to call it recurrent. That raises the likelihood that it's going to be MOG positive. Although, again, if you did find one of these, that also predicts recurrence, although then I would expect different lesions. Rarely does this evolve to MS. And you can see some higher numbers, but if you use strict criteria and actually include only children with encephalopathy, it's single-digit recurrence risk or evolution to MS. I'm only going to say a couple things about these. We don't have slides of these or anything, but occasionally ADEM is not so relatively benign, I guess. One is acute hemorrhagic leukoencephalopathy. So this could be a child who has ADEM and over the course of days to even a few weeks, maybe even doing better, then has a sudden decline, and you repeat their MRI scan, and they have hemorrhagic lesions in the areas of demyelination. And this happens in adults and children. It has a significantly higher mortality and morbidity with it. It used to be just thought to be universally awful, fatal, but there are reports of people being aggressively treated and recovering fully. And then this acute necrotizing encephalopathy of childhood, this really isn't in the same ballpark as the entities in this discussion, but it shows up, it's caused by two things. You have to have a genetic predisposition, and you have to have the right bug, which typically can be influenza. And they have often basal ganglia and other lesions. And at least on the surface, it might get looked at as, oh, it's this ADEM or something like that. But it tends to be much worse for children. So those are just a couple of other terms that the folks can look at. Let's move on to neuromyelitis optica spectrum disorder. So we're getting into the more likely recurrent disorders now. So ADS with core features. So optic neuritis, transverse myelitis are obviously in the name, basically. And Dr. Wu went through this pretty well. And one thing that there are reports out where you'll see if it's very early, or if they've been treated with high-dose steroids, sometimes the segments don't look as extensive as they may have looked at, at the worst. That's something to think about. So the other hallmarks, though, are you can have diencephalic involvement, periaqueductal gray involvement, or areopostrema. So these all have distinct clinical syndromes, or you could have cerebral syndrome with more typical findings. As Dr. Wu pointed out, diagnostic criteria, you have to have one core criterion, and really it's these three. His slide's better than mine is, so I'll leave that alone. And then of these, about 50% to 2/3 are aquaporin antibody positive, and it's relatively, if you've seen it, those don't show up in a lot of the other disorders. So that positivity really helps us as far as the differential. And that, I think, pushes us more to this being NMOSD. If you have recurrent NMOSD, that goes up. But up to 40% of these are also MOG positive. And so that's where, and these numbers obviously don't get up to 100. So it depends which study you're looking at. But you could have this, and you could, so a substantial number are still going to be MOGAD disease. But if you see this, you look at this, you think of this, and you think about the high recurrence rate. And about 20%, you get no help with serology. This tends to be a somewhat older group of children who have this. And there was actually a recent study from China that the children were older still. And females tend to be more common than males. Unlike multiple sclerosis, people of Asian ancestry have a higher incidence of this. And outcome, it's been suggested that outcome depends also on ethnicity and geographic factors, but it also may just depend more on treatment. And I think folks are still trying to sort that out. How does this present? Well, it either presents with optic neuritis, unsurprisingly, or myelopathy, although they actually don't present together a lot of times. If they have a diencephalic syndrome, the kids are excessively sleepy. They have endocrine abnormalities, including hyponatremia, SIADH, and personality changes, behavioral changes. If they have areopostrema, Dr. Wu talked about that already. The other less specific phenotypes can be just the tegmentum of the brainstem, so facial weakness and diplopia because cranial nerve 6 and 7 are being hit, other cranial neuropathies. They can have encephalopathy, but when they do, it's probably going to look more like ADEM, probably not going to be aquaporin positive, and probably going to be, and there's a good chance it'll be MOG positive too. These are the most, even though the things like the long segment, or longitudinal extensive spinal cord lesions are seen frequently in this, the diencephalic and areopostrema involvement are probably more predictive of aquaporin positivity. And if you have ataxia, then you start thinking about cerebellar problems, and especially the cerebellar peduncle, the middle cerebellar peduncle, that tends to be more predictive of MOG. Kind of like a broken record, scan everything, spinal fluid. This is an impressive pleocytosis for me. It's not, this is kind of start hitting into, is this a viral, is this an autoimmune thing? Is this a viral encephalitis? Is this an early bacterial meningitis? What's going on here? And so, less than 100 cells we deal with and can kind of finesse things. When you get up to this number, we start thinking, we probably should cover this child for things until we sort this out. What's going on? That's a lot of cells. Elevated protein, may have elevated IgG index, which confuses things sometimes when you're looking at MS. Although thankfully OCBs are less common. And then we do the serum studies. So this is the one that, even though it's not MS, there can be significant long-term morbidity for children with NMOSD. First is relapse rates really high, and they relapse pretty quickly. Second is, long-term, 33% may have, significant vision loss, and over half have visual deficits overall. 25% have cognitive disability, and this could be subtle, but enough to mess up school. A third or so will have motor disability. And so the expanded disability scales, if you've never seen these, their series of MedCalc has a great just thing you can use, little tool you can use to go through, but they're also written out. But moderate disability, you'll walk and talk and go to school and do all those things, but you'll know that you have some issues going on, which may affect your life to some degree. And so that's significant, compared to these other disorders we've talked about. That's a significant amount of morbidity. Poor prognosis if you're atypical, basically. Then also, interestingly, if you have optic nerve involvement early on, or if you just have a more severe clinical nadir. MOG, if you have MOG, it's better, although recurrence risk is still up there. And so that helps us separate out these two. Moving to MOGAD. This really is kind of the exciting, I think, for the past 7 to 10 years has been kind of 8 years has been the exciting kind of thing to think about, because it seems like, gosh, there's a syndrome there that we should really sink our teeth into and understand all the ways that this presents. It's fairly protean though, as we've kind of shown. So it's common, 34% of all childhood ADS. It's more common in children than adults, as opposed to MS. And females to males are about 1 to 1. It's interesting. If you look at development and myelin development, this thing about genetics is, our brains are different at 6 months and 2 years and 10 years, and we're expressing different genes. So we see different, our immune system see different proteins that are being expressed at different parts of our lives. And so MOG expression is quite early in life, which makes sense, right? Because this is when all this active myelination is going on. And so that may be some of the reason why younger children tend to be more affected than teenagers. That's speculation on my part, though. So clinical presentation, basically you could have an ADEM picture plus optic neuritis, and some version of this is probably especially in younger children, probably the biggest group, but then just could have isolated encephalitis or these other parts. How do you make a diagnosis? You have to have a core clinical demyelinating event, and for this, an ADEM picture, optic neuritis, or transverse myelitis are really the core demyelinating events that we want to see. The other things like the cerebral forms or the posterior fossa are less specific. And then you look at the supporting features. And as Dr. Wu had gone through with the type of lesions that you expect to see this versus some of the other disorders. So use those to support having one of those core features. Does it really fit well? And then you have to have titer positive or MOG titer positivity. And this is actually this is right now. The previous guidelines said you could use any of these, but they just published a proposed set of guidelines in January of this year, and that's what this is going to look like. And everybody who's written about this in the past 10 years is on that group, so it's going to be approved. And then you have to exclude diagnoses that make more sense, but that makes more sense too. Evaluation, MRI, CSF studies, about half will have some degree of pleocytosis. You can see oligoconal bands, so that can lead you to some thought, but it could still be MOG antibody disease. And then serum studies, there's a thought that should you be, do serial titers, because there's evidence that if you have persistence of titers, that predicts recurrence more than if it's just a one and done sort of thing, which makes a difference for treatment. Most children do very well, although younger children, very young children with it could have cognitive disability that hangs on. There's a lower relapse rate than certainly with NMOSD. Even with MOG antibodies present, it's persistently, it's still not that high. 25% recurrence if presenting with this, about 10% if recurrence with the ADEM picture, which kind of fits with ADEM. And most of the time, with these scans, we're going to talk about these things. We will repeat MRI scans to see what cleans up, and you may see some what look like new lesions on that 3-month MRI scan, but that doesn't necessarily mean the disease is progressing. So last, Dr. Wu started with MS. I'm going to finish with MS. It's just what we have talked about the longest, certainly, and maybe in some ways understand the least about. So pediatric cases, again, are a minority of MS cases overall. And even more than that, once you get down the early part of puberty and below, it's less than 5%. So a lot of the older teenagers are overrepresented. It has been reported in 2-year-olds, however. Here's the incidence. And yes, we all know that one of the slides I remember from my freshman year of medical school in 1983 was the temperate band of MS in the temperate climates across the world. So females more likely to be affected than males. These seem to be the big risk factors, and some of these probably inform how that geographic band is made. And it's interesting. So this tends to be, this HLA haplotype does tend to hold up worldwide for the most part, although there are selected populations both in the United States and in the rest of the world where other haplotypes are overrepresented a bit more. But if you had to if there were a board's question, this would be the answer. In the past several years, childhood Epstein-Barr virus has been implicated in childhood, and so don't let your teenagers get mononucleosis. Vitamin D deficiency, smoking, and obesity, and secondhand smoke is included in this. And then, as we talked about, diagnosis, you have to have disseminated in space lesions and disseminated in time. Children are almost exclusively going to have relapsing remitting MS. And if you see a child with what you think is a primary progressive multiple sclerosis, or you get this on a radiology requisition or a certain order, I guess now, it says possible primary progressive MS, I would start opening up my diagnostic windows really widely to look for other things, because the chances are it's not that. It happens, but it's rare. So an MS attack is some sort of focal or multifocal CNS dysfunction without fever or encephalopathy, distinguishing it from ADEM, lasting longer, at least 24 hours. Again, not hyperacute, but more on the matter of hours to a few days. Vision loss, spinal cord lesions, other long track signs, ataxia. The classic intermedullary lesion is intranuclear ophthalmoplegia involving the horizontal gaze center and cranial nerves 3 and 6. But you can have anything basically. But typically, again, no encephalopathy, and that's one thing you need to, I think, most important thing to take from this. Workup. You cannot diagnose MRI solely on MRI findings. Then you have radiologically isolated syndrome. Although you can certainly back your way into the diagnosis from seeing that, but we have to have something else. CSF examination is it's actually most helpful if non-MS diagnoses are being considered. There were in the 2011 McDonald criteria versus 2017. In the earlier criteria, you did not need CSF CSF was not particularly helpful to diagnose multiple sclerosis. And the big change in 2017 is that when we fall short on clinical and radiographic criteria, the CSF now becomes helpful. And specifically the finding of 2 or more CSF unique oligoclonal bands becomes helpful. In adults, it's very common to see these. In children, it's less common to see them, but certainly in a sizable minority or the majority of children, we see them. Serum studies, if you get high MOG titers or high aquaporin antibody titers, that points you away from MS. But one of the mistakes that we can make is to see low level, especially MOG titers, and say, oh, well, they have MOG. Well, they may not. They may just have MS. And this is a non-specific finding at low levels, and that's important for us. So I would, again, when you're trying to interpret, report films or images, and you're getting this clinical information, to kind of question those sorts of things if you're trying to get context. These are the McDonald criteria. You can look these up, but basically, if you have two or more attacks, and you can show on clinical signs that you can confirm those, then you've met the criteria for MS. Once you start getting away from that, and you start getting to one attack and so on, or one lesion, then you start having to rely on other things, and that's where the radiology starts coming in. And then once the radiology plus the clinical picture can't help us, then that's when the CSF oligoclonal bands come in. So there's some caveats with this, especially in children. First, an ADEM attack cannot be considered first MS attack. You can, again, 6% of children with ADEM go on to have MS. You just can't use that first attack with encephalopathy of fear as part of the criteria. The sensitivity, if you looked at the 2017 to 2010 criteria, and this tells you where we're at. So overall, sensitivity of these criteria, 83%. Specificity actually is lower at 73%. Although interestingly, and this was a big thing with the 2010 criteria, there was people didn't feel comfortable applying those in children under 11 years old, or 11 years old and under. And they found that the current criteria do better than the 2010. Sensitivity is extraordinarily high. Sensitivity or specificity is better than in adults, interestingly, although it's still not where you quite like it, because you think, okay, if I'm going to make a diagnosis of MS in a 6-year-old, then I'm going to put that child on a neuroprotective agent, some sort of a disease-modifying treatment, and that can have some pretty significant side effects. And so you have to be careful there. But we can probably help ourselves some there by doing things like, if we have true MOG positivity, or if we look for these criteria, encephalopathy, if those are strictly adhered to, then this number goes up. But you still have a small population where the clinicians are trying to figure out, what do I do with this child? Does he really have MS or not? The goal is to have high sensitivity, though, because we obviously want to start disease-modifying therapy as soon as we can in MS, because we want to decrease the amount of morbidity with it. Prognosis. So children relapse 2 to 3 times faster than adults. So adults, it may take years to get a diagnosis. Children, within a year or certainly 2, you're probably going to have a diagnosis. They relapse much quicker. They also return much more quickly to baseline, and it takes them longer to get to a level of disability. But since they've started earlier at a given age, they probably have more. They're younger with the same level of disability in adults. So it takes them longer, but they have more disability at a younger age than an adult does. Basically, that's what I'm saying. One thing that we don't do enough of, and I think I would do this with MOGAD, with NMOSD, is that we should be getting neuropsych testing with children because they often do have subtle cognitive difficulties, if not overt ones. And this just shows about 50-60% of kids with MS have at least one learning domain deficit, and 2 domains about a third. So differential diagnosis for all these disorders, and you can kind of lump them based on where it's the involvement is: brain, cerebrum, brainstem, cerebellum, spinal cord, optic nerve. So systemic inflammatory diseases, e.g. lupus, infectious diseases, direct viral infection. One thing that has shown up for us intermittently over the years is acute flaccid myelitis. So this is in the differential for Guillain-Barré syndrome and for transverse myelitis, but it looks different. It's asymmetric. It's almost exclusively motor. So you can get, and it's very patchy. It's polio basically, except it can be from other enteroviruses. So one arm, one leg, or one part of one motor unit, set of motor units in a leg, those sorts of things. It can, and the problem with this is that this doesn't respond to immune modulating drugs. This doesn't respond to steroids or IVIG, and because it's a direct viral infection of anterior horn cells, and the outcome tends to be worse for the involved area. And that looks different radiographically, I think, a lot of times, and I'll let all you guys all know about that probably better than I do. Other post-infectious things such as Guillain-Barré, toxic metabolic disorders. So, I've seen this before: heroin-related leukoencephalopathy, carbon monoxide poisoning, PRES, and so on. Granulomatous disease such as sarcoid, genetic disorders, vascular things, and I've listed some references at the end of this, and the articles, especially from 2020, have very nice tables of extensive differential diagnoses for these sorts of disorders. So what else do we get on spinal fluid besides cell count and protein and glucose? Well, get gram stain. We usually have some sort of a PCR-based panel or antigen-based panel, depending on where you're at. We have oligoclonal bands, which we talked about. We get an IgG index. We may get, if we think about sarcoid, we get an ACE. And then we have to think about these other things. We do not test for HTLV1 in Indiana much, but certainly in other parts of the world, that would be much more at the forefront. Blood studies. Again, looking at rheumatologic things, looking for non-specific indicators of inflammation. This is where MOG and aquaporin 4 antibodies are done, and so on. Urine drug screen, as I talked about, for like heroin and things like that. Throat and swabs for enterovirus and influenza, since influenza is a big actor here, and COVID, certainly causes these things. And then if things don't fit very well, we might do other stuff, looking for other diagnoses. Some of the testing pearls I think about is that early, as I talked about, early MRIs may be normal and require repeat studies. I think generally we all want to repeat imaging a few months down the line. We should be using MRI for once we start the neuroprotective therapies. It makes us worry when the spinal fluid is atypical. Oligoclonal bands are not specific for MS, but they are concerning for it. And that we should do a lot of these antibodies. And this is something we harp on people nowadays. Treatment, we have to establish level of care because some of these children are critically ill and belong in an ICU. We have to don't forget about their blood pressure and their bladder and things like that. If you come in with a bunch of cells in your spinal fluid and look sick, I'm probably going to cover you with antibiotics and encyclovir. If we think it's MS, we should start looking at these other things, that can be contributing factors. Most of the time, we're going to treat first attacks with high-dose steroids, methylprednisolone, 30 per kilo, up to a gram a day for generally 5 days. If we do not see improvement, within a few days, we often will push to do something else. Plasmapheresis or IVIG, again, divided over 3 to 5 days. It's important to do these, to not do IVIG and then plasmapheresis. This would seem self-explanatory, but I've seen this happen. And so you do either one or the other generally, but please do this before this if you're going to do them both. And then if we still have incomplete recovery, we often will go to rituximab, one of the monoclonal antibodies, which is being used more and more in adults and children to help. Chronic therapy, if monophasic illness with good recovery and low risk of recurrence, you may not need to do anything. So ADEM would be the kind of poster child for that. If there's a high risk of recurrence or actual recurrence or incomplete recovery, but not MS, right? So severe MOGAD or NMOSD, then often we will embark on a 1-year course of monthly IVIG. And then sometimes we'll go to Ritux as well, and that could go on for quite long, for 2 to 4 years. If it's MS, then we start a neuroprotective agent. I'm going to skip those. Currently, the FDA-approved drug for children is fingolimod, and the Paradigm study demonstrated pretty good results. You can't have seizures with it, and you have to do it monitored because of that. There are others, which I won't go through. A lot of these are some of these are still in trials. This we don't use as much. These were what we used to use a lot, and I think folks are getting away from these some. They're parenteral, so kids don't like them, and we've got some better agents now. Okay. Now we have a case here, and I think, Isaac, Dr. Wu, do you want to do the MRIs as I hit them, or do you want to kind of save them to the end before we go off into left field with what we did at the end?
No, I think in the sake of interest of time, I'll just show the images while you present the clinical picture.
Okay.
I think that probably works.
Okay. So I'll start off, and if you want to, it's probably better if you share your screen, and
yes,
and I will pull up my stuff. So, okay, so you should be able to. Yeah.
So it's like a similar situation that you come in the reading room, present some information for us, and we're gonna go over the imaging finding with you.
Right. So if I did it like this, I probably would have to wake you up in between because it's long, but I'll try to talk back. Okay, so this was a 12-year-old boy with previous history of ADHD who presented with right-sided weakness and cognitive changes for 8 months. He was actually seen someplace else initially with 2 weeks of progressive right face, arm, and leg weakness. He was known to be, his mother had said he had been limping first, and this progressed to his arm, and then his right face, and then he had slurred speech. He also had some right-sided numbness, and then the neurologist exam at that point confirmed these findings, and he had some hyperreflexia. So he got an MRI scan, and I think this was the first outside MRI scan, Dr. Wu.
Okay. I'm just going to spare some of the trainees' anxiety, so I'm just going to pretend that I'm looking at this case here for the first time. So it looked like on your right-hand side, you have flare sequences, and I selected the post-contrast, and T2 looks exactly the same as the flare sequences. So based on the symptom or the clinical information, and the first thing that I think everyone can see very clearly that you have a relatively confluent area of abnormal T2 / flare hyperintensity, kind of involving the periventricular white matter, but a lot of them involving the deep gray, involving the caudate nucleus. You can see there's basal ganglia involvement, thalamic involvement, and with extension sort of into the cerebropeduncle and all the way down to sort of the lateral medulla. And that's a major key finding for the flare sequence. And does not project as well. I think there's also some other smaller, less obvious patchy lesion. The key thing here is that, of course, you do not see any enhancement at that time. On diffusion weighted sequence, and this is from outside, they did this technique called EADC as well as your typical ADC. So ADC, I think our training are very familiar with. That's the counterpart to DWI. So you're looking for something that's bright on DWI, dark on ADC. And in this case, you don't really see it compared to the normal side. I know there's a lot of motion, so it's hard to discern. But there's not a lot of ADC low signal, so i.e. not a lot of restricted diffusion. And on EADC, also the same signal. Just for as your reference, in case you go to a place that does EADC in addition to ADC, the easiest way to think about it is just if you see restricted diffusion on DWI, it's going to be bright on DWI, dark on ADC. For EADC, just to make things less confusing, so they thought, is that if you see bright signal on DWI, bright signal on EADC, that's restricted diffusion. So that's initial presentation. So at that time, we thought that because of the clinical finding or clinical presentation, as well involvement of patchy bilateral area and basal ganglia, ADEM was pretty high on the differential diagnosis.
Okay. Let me get over to my, okay. So they did a spinal tap initially. Thank you, Dr. Wu. They did a spinal tap initially, which was normal, including negative OCBs, myelin basic protein, which we didn't talk about in this, and it's less specific. Normal IgG index, serum MOG antibody was negative. He was treated with methylprednisolone for 5 days and had mild transient improvement. Then he presented again 3 months later with worsening right arm and leg function. He was also struggling at school and had some personality changes. He was disinhibited on exam, and then the other findings were confirmed. And then he had an MRI at that point that was read as improved, but with possible new remote lesions. And I don't know if we have that image or not. Dr. Wu, do you have?
We have, well, just a selected slide. I don't have the stacked images, but it's I know it's kind of hard to just look at without comparison directly. It was thought that maybe that lesion, again, it's pretty obvious that you do have quite a bit of involvement in central gray, but it was thought that that's a little bit thinner, and the signal persists extending into the cerebropeduncle, but at that time thought was more Wallerian degeneration that's going down. I can sort of see like the left cerebropeduncle is a little bit smaller. I don't have that image that shows another lesion, but the main lesion seems to be just a little bit smaller.
Okay, thank you.
And then no enhancement again.
And then, so, yep. So he was treated with, again, but this time with oral high-dose prednisone, again with minimal improvement. 1 month later, he was seen by then a second neurologist and was noted to have, again, spastic hemiparesis with 4 out of 5 strength in the right hand and arm. And they thought they maybe had seen a T1 hypodensity on the previous month's MRI scan on the one that Dr. Wu showed. And then on another image, I think. And then he got 3 doses. They said, well, this isn't getting better. Let's give him IVIG. So he got 3 monthly courses of IVIG. And they did a bunch of starting to look for other things in addition. So serologies were done for autoimmune diseases, but they also looked interesting for hexoaminase A deficiency and aryl sulfatase, which is what you would see in metachromatic leukodystrophy. That was not completed though. At the very end of his third IVIG infusion, he was then admitted to our hospital with severe worsening of hand function. And it was interesting. A day prior, he was in PT, and they noticed that his wrist was, he couldn't get his wrist extended, and he couldn't spread his fingers apart or bring them together to a pose. So he was quite weak in that hand. Excuse me. And retrospectively then, family thought, even though they were getting these little bumps of improvement in his motor function with steroids or IVIG, his cognitive function really seemed to be on this gradual slope of decline over that several months. Excuse me. Water. So that was concerning. Examination revealed him to be alert, pleasant, but he was disinhibited. He was having word finding problems. He couldn't name like watches and stuff. He had his prosody of speech was unusual. He had motor sensory losses on the right. Interestingly, his tongue deviated to the right. He had some, but his arm, his hand, it wasn't just weak, it was dystonic. I mean, he was posturing, and that was actually probably the big reason why he couldn't extend it or couldn't use it as well. It wasn't that it was that much weaker, but he was dystonic. He also had some extrapyramidal movements of his shoulder, of his upper right arm. And then he had long track signs, and his gait was broad-based and unsteady. So we repeated his MRI scan at that point.
So, thank you. So at that time, I believe this is the first time we actually did the MRI spine. Maybe we did one before, I don't remember. But this time the spine was negative. So we look at the brain MRI again. This time, the things that's a little bit different is that, again, the lesion doesn't look like it's changed all that much. If anything, it may be just a little bit thicker. Not a lot of restrict diffusion, as you can see on DWI is bright, on ADC is not specific dark. But you do start to see some faint enhancement, which is not seen previously. On the spectroscopy, we also do this time, is that this is a normal side. We always, as many of you know, that we need to have a normal reference level. Sometimes that's helpful just to assess the quality of this particular spectroscopy. This one, the voxel placements on both of them are long echo. You can see that voxel placement on the right basal ganglia shows the classic normal pattern of Hunter's angle. The NAA should be the highest peak for normal neuronal tissue, followed by creatine. Then the choline, you should not see any lactate elevation in a normal brain tissue. On the other side, where the signal abnormality basal ganglia is, you can see there's some depression of NAA in the sense that the choline and NAA is relatively about equal height. So that tells you that the brain is under some process. So that's very non-specific finding. Just tells you that the NAA is neuronal health markers. Therefore, mild depression suggests some type of process. The severe depression obviously is something worse. Could be a bad neoplasm, bad inflammation, etc. But on this side also has a mild elevation of lactate. But the interpretation of this is that this does not look like your typical picture of a high-grade neoplasm, more in line with some type of ischemic process or some mild elevation of lactate only. In the high-grade pattern, typically you have a reverse Hunter's angle. In that choline would be much more elevated, NAA depressed. Sometimes you can have a severe elevation of lactate. So again, going back to the anatomical imaging, I think this is sometimes we kind of fall as a radiologist. I'm guilty of this more time than I care to admit. It's that sometimes you have a mind set up to see a diagnosis, or you think you know what the diagnosis is. You continue to find the finding that justify your answer rather than sometimes hold it back and start to think about, wait a minute, that doesn't make sense, right? What should have alerted us perhaps a couple images ago was it does not make a lot of sense for ADEM or demyelinating process that continue to show very little improvement. If anything, it's getting worse and start to show some mass-like effect. even though the spectroscopy also doesn't quite show the picture of a neoplasm, if you will, at least not high-grade neoplasm. And then I think we did another scan afterwards. And this is a couple days before. Larry, I think something also progressed again in few days.
I think we, yeah. So I think we did. So we repeat. So basically, we had done his. We did this MRI, and then we treated him with steroids again while we were doing everything else, starting to look for other things. We repeated his spinal fluid. Interestingly, he had oligoconal bands, which were CSF-specific, two CSF-specific oligoconal bands in his spinal fluid, although everything else was negative. We also did very long-chain fatty acids, lysosomal enzymes. These were all normal. We actually consulted neurosurgery and oncology because we thought that things were atypical. And then this is where we repeated the MRI and MRS, and we sent whole genome. We actually did conventional angiography, which we probably don't need to show that today, but it was unremarkable, I think. And then, so we did actually 2 rapid fire MRIs then as we were kind of going through this final part of his diagnostic workup.
And finally, when right before patient went to get biopsy, you can see now the lesion has progressed, is much thicker now, and in addition, now clearly there's a lot of more contrast enhancement just compared to a short time ago. So now the picture begin really look like more a neoplastic process as opposed to other processes. And then sure enough, the patient undergo biopsy a couple of days ago. This is just a fast span just to show you that there's some blood products, a subfield artifact from the area that was biopsy. And the path is Dr. Walsh.
The path showed dysgerminoma. So this, and it was actually interesting, and a lot of the course of that last week he was in was hemming and hawing about how to do this, because I think everybody was concerned that this was no longer a demyelinating disease, but we knew where the nidus of this was, in sitting in his globus pallidus and his internal capsule, and no one wanted to go in there to look, and so you could kind of see where they had to do the biopsy. It was more peripheral, but we were afraid that having the neurosurgeons do it there, and the neurosurgeons were afraid that they would get non-specific gliosis or lymphocytosis, some perivascular infiltrates or something. But we were fortunate, and we're able. And for this young man, this is a treatable disease. So hopefully he will do better with this. But.
Wow, thank you so much on this one. I think I read maybe like a sum of the study in this patient. And when we go, Dr. Wu, when we go back to one study that you show, I think there is some volume, some volume loss, right? Like a atrophy, virulent degeneration of the cerebral peduncle. That one, yeah.
Right. Sorry, my mic was muted. Yeah. So there are even back in 2022. So the early yes, there is a sign of Wallerian degeneration. So that may perhaps that should be another imaging clue for not a acute demyelinating process that should not do that. And I think Dr. Walsh and I think that this is a great case just to highlight, even though we talk about different disease processes, that a lot of time you just we always go to the conference that people show the most beautiful case, most classic case on the textbook, etc. But a lot of time medicine is just not textbook, so we just throw as a curveball. So it's a great learning case.
This is a tough one. This is a tough one.
Yeah. I think it was one of those ones where we knew early on, once we met the child, that something wasn't right, and I think it took, and I think we were on to the right track early on, but then realizing what had to be done to get to a diagnosis also given the uncertainty, made it very hard, because everything we went from least invasive to most invasive in doing that, and so I think it was difficult for everybody, but we got there. So
when we look back on this one, can we say that for the demyelinating disease or ADEM that we call to start with, so after treatment it should be complete? I mean, we should not see any residual disease at all. Can be the teaching point here?
I think so. I think that if you looked, I mean, the basal ganglia involvement early on and where it would fit more with ADEM or MOG than with one of the other syndromic demyelinating things. And so once you're in that group, they should respond to therapy. So I think that's probably the biggest teaching point. The other, if you think, well, is it just some really refractory version, then what could that be? NMOSD doesn't quite look like that. Then you go to primary progressive multiple sclerosis, but that's unusual in children. And I think to the credit of the, and I would not fault the folks before at all, because they were moving along. The first neurologist realized that this was not right. This wasn't he did not respond well over the course of his initial treatment. So he sent him to another person who actually is an MS expert, who looked at this and said, yeah, this doesn't look right either. So even while he was giving IVIG, he was starting to look for other things. And then finally, the child just got acutely worse where he came in, and then we could do a lot of things in a concentrated fashion.
I think for radiologist perspective, it's also important for us to remember that a lot of time we interpret the image in vacuum. So without a lot of clinical context, you're going to misinterpret it. Your mind is set up to go in one direction. So it's extremely important that if you can talk to your clinical colleagues and get what their input, that would make us a better radiologist and help us with a different search pattern as well.
And I think in the radiology, to give props to the radiologist too. I think that when we went down and talked to them the first time and said, we're concerned that this may be neoplastic, they actually were the ones that said, well, it doesn't look like a glioma. Maybe it's a dysgerminoma. And it's like, okay, they were right. It was. So, shout out to you guys for doing that. So,
but this is very impressive case. Thank you so much for showing us this one. Yeah, an excellent talk as always. Yeah, a lot of clinical information. Something. Any questions from the audience, from IU?
All right, can you guys hear me?
Yes.
No, I think I was on mute earlier today, so I apologize. But thank you for the lecture, Dr. Walsh and Dr. Wu. That was excellent. One question I had specific for Dr. Wu is that I know that in terms of finding imaging characteristics to help differentiate between ADEM and MS, we talked about the T1 black hole, or the T1 hypotense lesions, which is pretty specific for MS. Now, if I were to dictate a study and I saw that, am I able to effectively rule out all the other kind of demyelinating conditions, or can theoretically any chronic demyelinating condition cause a T1 black hole aside from MS?
I think other chronic can kind of depend on, again, none of them is our pathognomonic feature, right? It's just a little clue that may lead you toward certain diagnosis, supposed to that take one feature and say that's exclusive of one disease process. If anything that you see on this talk is that there's just so many overlapping features. But if you see T1 black hole, if you see the lesion that look very classic of the Dawson fingers, involving corpus callosum, etc., then of course I'm going to lean down toward MS much, much harder than anything else. But yes, it's less common.
Thank you.
Of course.
I think we have one more question from Namphon, Dr. Namphon from Thailand. Yeah, before we're gonna adjourn this session.
Okay, can I ask? At first, I want to thank for the interesting presentation of both of you. And can I ask about acquired demyelinating disease that often has overlapping clinical findings and imaging findings also overlapping both clinical and imaging findings? And do you have any clinical clue to help you with more specific diagnosis?
So, I think that the big ones for me, so ADEM, is pretty straightforward, right? You're looking for encephalopathy. And I think, then I think the next one probably becomes MOGAD, because they, I think age helps with MOGAD, and but I don't know that I could take a child who has, and maybe an ADEM-like picture and tell you if it's going to be MOGAD positive or MOGAD negative, ADEM, frankly, based on just clinical picture. So I think the short answer, once I get past, or an MS, obviously, if they have the history for MS. So I think short of an obvious florid or initial presentation of a multiple sclerosis, or at the other end of the spectrum, ADEM, I think everything else we probably need the radiologists to help us with the picture. So I think that's probably the best I can do with that. And then I think somebody had asked on a chat, there was a question, how do we explain the CSF oligoclonal bands in the last case? God just wanted to fool us. No, I think that so oligoclonal bands are not specific. They are, and I think that when we were going through, which we saw those, and actually it always went back to our books and said, okay, all the things that can do this. So basically neoplasm, so tumor, you can see it in tumor. You can see it in, we did JC virus, looking for the causes progressive multifocal leukoencephalopathy. You can see it in PML. You can see it in other other connective tissue disorders. And so there's actually quite a long list of things that can produce oligoclonal bands, and they can even be, if it's not a systemic process, they can be unique CSF oligoclonal bands. So they're helpful, but they're not diagnostic by themselves.
For the sake of time, thank you so much, both of you, for the excellent lectures, combined teamwork to show us combine things together and make it more clear for us. And I think this is very useful topic for us because we see things and we know it's a lot of overlapping, and sometimes we just, okay, what should we tell you guys? Or maybe we want more clinical information, and how can we interpret those clinical information? Because
Froze.
Froze. Yeah. That's how we interpret clinical information. We just freeze.
I appreciate you guys inviting me. It was great fun.
Thank you, Larry. So thank you, Dr. Walsh. This is a great talk.
Oh.
So we'll just end right here, and everyone have a nice evening and have a good day. Thank you so much.
Bye-bye.
Thank you so much. Thank you, all of you. And this is the last session. We are also grateful on behalf of Julapon Royal Academy. We thank you all speakers, and especially Dr. Nucharin, who create the lecture series about pediatric neuroradiology, not for all of you that have the regular lecture, but for us radiologists in Thailand, and as well as the healthcare worker that work in radiology department, and as well as ASEAN radiologists like this. So thank you so much for give our excellent talk tonight. Tonight in Thailand also, but you're in the morning. Sorry.
It's okay.
Sorry. Okay. Have a good day. Thank you so much.
Thank you.
ขอบคุณมากนะคะ Thank you. Bye bye.
Bye-bye.
สวัสดีค่ะ
Thank you.